Hello, everyone. How are you doing today on this beautiful Wednesday, May 26th? Today is an awesome Ask the Experts because it's Liz and I. We have had guests on for a while now. And so Liz and I used to doing just the two of us for a while. But it's been really cool having different guests from the community, whether they're clinicians with lived experience, clinicians talking about specialty topics. But it's always fun. It means Liz and I are going to get through a lot more live questions and pre-submitted questions. So just to tell you about the live real quick, this live is all about you. When we do a Ask the Experts, and it's Liz and I. We're going to answer all your questions. We're going to give resources out. Amanda on the IOCDF in the background is going to be putting in stuff in the chat, some resources and stuff. So today's live stream, for it to be successful, we need you to jump in. We need you to ask questions. We need you to submit stuff. So whatever stream you're on, whatever platform rather, whether it's X, whether it's Facebook, whether it's YouTube, whether it's Twitch, whether it's LinkedIn, just in the comments, just put a question. If you have a question about certain books or resources or anything that we can support you with along your journey, please go ahead and do that. But I feel, Liz, like we haven't introduced ourselves in a while. So why don't you introduce yourself to start?
Okay. I'm sorry, guys, if I just like a pre-warning today that Houston got hit really bad with the storm, and here at our clinic we still have no power and no Wi-Fi, so we are bare minimum over here trying to survive, and I'm on a hotspot. So I apologize if things pop in or out or something happens. Chris has got your back today, and just know that I may or may not be totally here. My name is Liz McIngvale. I am a advocate for the International OCD Foundation. I'm a national advocate. I've been doing advocacy with the foundation for 20 years, which is kind of crazy, but also incredible that it's been that long at this point. And I am the director of the OCD Institute in Texas. We are one of the few residential OCD and anxiety specific programs in the world.
Yes, absolutely. And my name's Chris Trondsen. I'm a lead advocate here for the IOCDF. I'm also on the board of directors along with Liz. And I work at a treatment center called the Gateway Institute in Orange County, California. And like Liz, I have OCD. So we mainly talk from a clinical lens, but we also sometimes throw in our own experiences. So welcome to live. Like I said, announce where you're from. Where are you visiting the live stream from? I know we get people from all around the globe. So in the comments, just put where you're from. And like I said, you could say, hi, who are you here to support? Are you here to support yourself, your child? Are you a clinician? Are you a new clinician? Are you a seasoned clinician? And also any questions that you have. Always to start off the live, we just want to remind everybody that we are here to really provide resources. IOCDF is the largest organization on the planet helping people with OCD and related disorders, and has a great community both here in person, etc. But we also cannot be a crisis hotline or a crisis support. So if you are really struggling, if you're in a crisis, please, please, please go to your local emergency room, dial 911. You can dial 988, the suicide support hotline, a crisis hotline rather. You can also go to 988lifeline.org. So please, please get help. Also, we are recording this. All of our live streams are available for future visit. I've seen you can go on X and go under IOCDF's account and watch it. You can go to Facebook or youtube.com/IOCDF and see it. Before we jump into questions, Liz, how are you doing? Has there been anything that your clients have been talking about? Any topics that are really hot for your groups? Anything that you're really passionate about that we can talk about a little bit before we jump into questions?
Great question. I think that I don't know that there's like a hot topic now. I think that people are struggling. We tend to find summertime is a really great time for people to dive into treatment, and that people really want to be able to come in and do the work so that they can get back to their fall semesters at school, work, wherever it is, and be as productive as useful and as productive as possible, and be managing their symptoms. So I think summer is certainly a great time to hop in. What else? I'm trying to think. What else has been being brought up? I think that I would love for us to focus on talking a little bit about like habituation and a SUDS model and why we've kind of gone away from that and how treatment looks different. So maybe for folks who've been in more residential or intensive treatments in the past, if they were to say to me like, oh, how does, like, for example, I was in treatment 22 years ago, an inpatient, and treatment is very different now than it was back then. Although outcomes are still incredible, outcomes were incredible. The way we do ERP looks different. So I would love to talk about that today. But what about you? What have you been hearing? What are some of the buzz things or things you've been getting asked a lot about that you want to make sure we cover today?
Yeah, I think one thing, so I run a teen and young adult support group, and right now is always a triggering time for a lot of people in that age range because it's the end of a school year. So there's a lot of finals, there's a lot of finishing up. I have clients that are seniors that are graduating and going to be going out of state. I have people that are finishing college and moving back home. And people have asked me, I don't understand why my OCD is so bad right now. So, what I always want to remind people is that if you have a lot of life strife going on, and it doesn't always have to be negative, it could be positive, but let's say you're graduating, let's say you're getting married, let's say your job is laying people off, let's say you just got a new job. When you have those kind of life transitions, those life changes, it tends to elevate our overall just like lack of control, doubt in the situation, uncertainty about life, angst, anxiety. And I'm not surprised that in those moments, OCD absolutely takes advantage to really, really try to take over. So that's just something I want people to watching to be aware of, is that if you are going through a lot of life changes, maybe planning a big trip, etc., don't be surprised that that's an opportunity for OCD to get really loud and invasive. So always kind of be on the lookout for that. Notice that OCD tries and tends to demand more around those life transitions and changes.
100%. So let's talk about all that today, but let's start with questions. It'll be kind of fun to start with questions, and we'll get to some of our stuff and then go back. So first question is from Bugan. Hello from Puerto Rico. Hi. Schizotypal personality disorder presents weird thoughts and weird behaviors. OCD also presents weird thoughts and weird behaviors. What's the difference between the two?
Yeah, so schizotypal personality disorder is very different than OCD. Personality disorders, just for those people newer to the stream or newer to personality disorders, they're very different than like an OCD and related disorder and anxiety disorder, etc. Personality disorders are basically a disorder where it's like the person's overall kind of like being, essence, personality, etc., is influenced by certain behaviors, certain diagnostic criteria. So in schizotypal personality disorder, I understand where there might be some confusion. It's where somebody has like really odd beliefs, really odd actions, and they're not talking about intrusive experiences, doing repetitive behaviors to try to ward something off. That might be somebody that just a lot of times people, I will say personality disorders are very rare. So that's the other thing. But this might be somebody who has very odd beliefs, like maybe they're kind of like off the grid. They believe in I think aliens might exist too. So yeah, I have schizo. No, I'm just kidding. But maybe they think like aliens exist. They're off the grid. They're wearing tinfoil hats, maybe, or like they're just like different, right? They're like kind of a loner. They kind of do odd behaviors with their family and friends. They don't have a lot of connections. They don't have a lot of people. Interacting with them might be a lot different. It's just, that's kind of like their being. I think with OCD, obviously, when we do behaviors, because I agree, I've done weird behaviors in the past, it was much more about we're trying to prevent something bad from happening. We're trying to prevent us from becoming bad people. We're trying to prevent harm from ourselves or others. We are still intact. We still understand it's ego dystonic. Like we understand that these things are not really happening. So what I see a lot of times with OCD is people read or hear about these type of disorders, schizophrenia, et cetera, and think, could I have that instead? And what I always want to go back to is like, just like clients with health-related obsessions shouldn't be diagnosing themselves with health-related concerns and shouldn't be like scouring the internet for medical advice, right? Leave it to the professionals. In this case as well, don't be trying to diagnose yourself. There's very specific criteria for personality disorders. So just make sure you're not hearing about certain disorders and then assuming you're having it and throwing away your OCD diagnosis.
Totally. Yeah. I think that, again, the big thing with OCD is that these are unwanted intrusive thoughts that we have insight over, that the fact that they're unwanted intrusive thoughts followed by bizarre behaviors. So you're right. They are both kind of bizarre in nature and the thoughts can seem similar. I think one of the big differences is that with OCD, there's insight into knowing these thoughts are irrational. I don't want them. I wish I didn't have them. And they're very, very, very what we call ego dystonic. So individuals don't want them. They go against who they are. They do these behaviors to get rid of the thought, versus anything that is more thought disordered, right, is can tend to be more of like they believe these thoughts. Individuals might think these thoughts are real. And the more somebody tries to help them see they're not, the more they think that person is like not telling them the truth, or, so there's quite a few differences in the diagnostic impressions. But again, let the clinicians help you differentiate that and go from there.
Yeah, I was going to say real quick, because I didn't realize the question went on, right? I spent hours, days, even weeks trying to figure out if a thought is OCD or if it's schizopersonality disorder. Schizopersonality disorder, like I said, when they say odd thoughts and beliefs, like the person isn't saying like, I'm experiencing odd thoughts and belief and I don't want them. Typically a person with that personality disorder is struggling with like personal connection. They often think they have special powers. They can move things with their mind. They can float, right? Like somebody doesn't have insight that they're going through something. Based on your next comment about you have an IOCDF trained and certified therapist in Puerto Rico, which is amazing, by the way, you know that you have OCD, you know that you need to go get treatment, where in the personality disorder that you're concerned about, they don't have insight. Like a lot of these mannerisms, behaviors, etc., the way that they dress, appear, very different, eccentric clothing, like they don't understand. There's nothing wrong with them, of course. They just don't understand that their thoughts are odd, whereas it seems like you do. That's why you have a appointment. So to me, it sounds like a lot of doubt, a lot of OCD, a lot of kind of like confusion and things like we see in OCD. And there's a lot of behaviors like researching. So this is fitting under an OCD category. And I'm glad that you're seeing a trained OCD specialist, because they'll be able to further guide you on ways that you can reduce the compulsive behavior, which is just causing more confusion than if you were to leave it be. Do you want me to ask you that question?
I'm frozen. Here we go. Next question from Rebecca at 1001. I have the same confusion. OCD and STPD have strong similarities. The experts explaining similarities and comorbidities would be great. So I know we talked a little bit about that. Next question is also very related. My question is, what is derealization and in OCD? I have the same doubt about OCD and schizotypal. You want to talk about derealization a little bit?
Yeah, I'm wondering if there was like it's funny because I remember what schizotypal personality disorder is, because when I worked at in undergrad, actually, my undergrad program was unique in the sense that they had us do practicum hours, not just in master's program like most people do. And I worked with somebody with schizotypal personality disorder. So I just remember this person very intently, but I'm just surprised because most people don't know the disorder. Leave it to people with OCD to find it, right? So I wonder if there was like a special or something that people saw. What we see is with derealization, there's also depersonalization. Those kind of go hand in hand for some people. Depersonalization is where you don't feel connected with you as a person. Sometimes people will say like they're floating and observing themselves. They feel disconnected from themselves. Derealization is more like you feel disconnected from the world around you. Some people say things feel kind of like off or unbalanced, or might be bigger or smaller around them. But the main component is you just feel disconnected from yourself and from the things around you. I think a lot of times when people think about anxiety and they think about like panic attacks, overt symptoms, freaking out, right? Like crying, yelling, just like a lot. I was like that with my anxiety and my panic attacks. But people also can deal with both OCD, and we see derealization, depersonalization, these dissociative disorders, and trauma, complex PTSD, for instance. It's the brain's way of saying what I'm going through right now is just too much, and I'm disconnecting from myself, from everything around me, because it just feels like too much. And so often, for instance, if somebody's doing things that trigger them. So let's say you're traveling and that's a trigger for you. Sometimes people will say, instead of kind of like having a panic attack on the plane, I sort of disconnect. I don't even remember really the flight, etc. The biggest mistake people make is they try to get out of it, right? They try so hard to get out of it. Why am I feeling this derealization? I don't want to feel it. It's causing me distress. Get me out of it. Get me out of it. Get me out of it. And just like in OCD with thoughts, just like in tides in the ocean, the more you try to get out of it, the more panic it causes, the more you kind of disassociate. So what the recovery for this is a lot of allowing yourself to experience these feelings, to feel them versus to run from them, to get to a point of acceptance and letting go in the moment. Because when you de-escalate your anxiety, you can often be present. A lot of times people find it helpful to really connect in the present moment. I've had some clients that will like chew mints or something, like smell something that's really strong just to reconnect them. But a big part of it is anxiety management. So I would say that with OCD treatment, a lot of people that experience it, once they start going through the treatment and really noticing that their anxiety is going down and they have an understanding of the disorder, this sometimes kind of goes away on its own, or people need to work on it specifically with a clinician.
Yeah, I'm interested in how many questions we're getting around this, but we do see this. And again, remember, if you have OCD and you're doubting if it's schizotypal, I would say it's a bigger indication that it's OCD, which is the doubting disease, and you start to worry if you have another illness. If you have schizotypal, you may not have the insight to recognize that this might be schizotypal. Does that make sense? So like oftentimes somebody with schizotypal isn't saying, I wonder if I have schizotypal personality disorder. Like they don't have that insight to have that recognition that might be what's going on. And so if you're asking that question, that may be a better indicator that this might be OCD or anxiety, making you wonder if it is that or if it's something else. So anyhow, just saying all of those things. So what else do we have? Next questions.
I think Matthew Bannister's question is great. We're not psychiatrists, but I do want to say, Matthew, so at 12:07, if I'm still in a good place recovery in the next few months, should I try weaning off medication altogether? We are going to have, part of the reason I want to put this question up is a big plug. We have Dr. Robert Hudak coming on the stream. Maybe Amanda will let us know in the private chat. I don't know the exact date, but one of the things that we always are trying to do is get psychiatrists on our stream. You loved him when he came the first time, so we're excited to have him back. One thing I say all the time is if you want to wean off medication, please, please, please talk to the prescriber. I hear a lot of times clients that feel better, so they go off the medication on their own. And what ends up happening is they have sort of a bumpy ride or things start to come back. So my biggest thing is talk to your psychiatrist. What I've heard a lot of them speak about at the conference is you want to stay on it for a while after recovery to really make sure everything's working out. But I mainly wanted Matthew to plug that we're going to have Dr. Ruda, his name, Dr. Oh my God, why am I butchering his name? Hudak. We have him coming on the stream Wednesday, June 5th. So definitely be back with that question. But also just please, everyone, make sure that, after you're feeling good, you don't jump off right away, especially on your own. Talk to the person who prescribed it and really create a program together. I think a lot of times people just kind of go off, and I don't hear many good stories when people do.
Totally agree. Couldn't agree more. I think it's really important to recognize too that everything is individualized. So for some individuals that makes sense. For some individuals, they're going to have a team and work and try it. The one thing I'll say is that if you're going to start to wean off medication, I want to make sure you're working with a team and that you have an active behavioral therapist. So if you did behavioral therapy and you got better, don't go make a big change without having that support there. In case you do see an uptick in symptoms, you want to know that you have support to work on that. So again, it is totally individualized, but it's definitely something we can talk about in our upcoming stream. I see so many people saying hi and talking about how much these streams mean to them. I love that. Sorry to hear, Spence, about you living in the Heights and just getting power back on Monday. It's been tough. More questions. So good to see y'all, Mexico City. Let's go to 1113, Matthew. Has there been any more innovative evidence-based treatment techniques explored with ERP, ACT-DBT, and CBT?
I would say that if you're talking about behavioral therapy, obviously exposure response prevention currently is going to be the gold standard kind of frontline treatment. I know there was a question earlier, or not question, comment about it feeling like hell. One thing that I want to talk about is like ERP, when we saw it first developed in the late 60s, early 70s to where it is now, it is a lot different. It's justice-based, it's values-based. If anybody, I want to just say this to anybody in the chat, to watching, if you feel like your treatment is hell, something isn't working, right? I can't promise you that recovering from anything in your life, whether it's a medical or physical, mental or physical condition, is going to be easy, right? Like there's going to be ups, there's going to be challenges, but treatment should be collaborative. It should make sense to you. It should be something you're doing with a clinician at a pace that's comfortable to you. So it shouldn't feel like hell. Acceptance and commitment therapy, which is a therapy modality that people use for other things, we found it very useful for OCD, whether that's the cognitive diffusion, the values-based work, really seeing the purpose. We know dialectical behavioral therapy can help people with a lot of angst, a lot of strong emotions, and really help with emotional regulation, any self-harm. Both cognitive behavioral therapy, the traditional type, inference-based CBT. For some people do want to take a more cognitive approach. There's some, evidence out there that those can help. I would say the only one that I don't see mentioned, we have motivational interviewing. Motivational interviewing is developed for OCD now, and it's really to help somebody who is absolutely in refusal of getting treatment or don't see value in getting treatment. So it's to help them to get better. One thing that I would always say is, like, when we look at OCD treatment, the goal of OCD treatment is to say, like, I've been creating so many blocks and so many resistance and avoidance in my life, and I need to start getting back into life. And there's specific techniques that help. So it's a very action solution focus. So when I work with somebody who says, I've tried the ERP, the ACT, the DBT, and forms of CBT, and it didn't work, a big thing that I always say is, are you at the right level of care? This is something that Liz can add on to, but Liz sees some of the most difficult cases of OCD in the world. People come from all around the world to come to her treatment center. I've had clients go to her treatment center or higher levels of care. And what I always hear from them is, it wasn't necessarily the treatment, because we have a lot of evidence-based treatments that really help, and it's done in a way now that's very values-based. It was just that going to a therapist once or twice a week and then going home and not feeling supported and being by themselves wasn't helpful. So I don't know how you feel, Liz, but for me, it's less about the evidence-based techniques, and it's more about sometimes just, does the person have the right medication and do they have the right level of care? Because we know the treatment works really effectively.
100%. Couldn't agree more. I think that what I'll say is that there are definitely different evidence-based treatments for different diagnoses, right? So we know that ERP is evidence-based for OCD. ERP and ACT can be useful for OCD. ACT is an evidence-based intervention for some different diagnosis. DBT is evidence-based for borderline personality disorder, and then CBT for many illnesses, from substance use, anxiety disorders, eating disorders, you name it. But what we know is that it doesn't mean you can use them interchangeably. So while DBT is an evidence-based intervention, it's an evidence-based intervention for borderline personality disorder. It is not an evidence-based intervention for OCD. And so I think sometimes we hear this word, oh, this is an evidence-based intervention, therefore I should use that modality. And what we know is that there's evidence-based interventions that are evidence-based for specific illnesses, not there's an evidence-based intervention that works broadly. So be really thoughtful about that. And what we know to date is that ERP is 100% the most evidence-based intervention for OCD right now. Doesn't mean there might not be more in the future. Might not mean that there's new ones being explored and tested. But what we know is that today ERP is the gold standard treatment, behavioral treatment for OCD. Often it's in combination with medication as well.
Yeah, thank you for clearing that up. And I always tell people, if you're not having ERP as part of your treatment modalities, there's something that's not quite working. And then people will say, but Chris, ERP didn't work for me. And I'll say, okay, describe an example of something you did in ERP. And they're like, well, my therapist had me like rub the bottom of my shoe and lick my fingers and then talk about my SUD scale. And I'm like, okay, what about instead? What is kind of your core fear? And they're like, well, that I'm going to get an illness from not having hands clean enough eating. And I'm like, okay, what if we work up to maybe going to the mall, we get samples of See's candy, and you eat that without washing your hands? Does that feel more like something you can do? And they're always like, yeah, like that makes sense. I'm out with my friends. I want to just eat snacks. I don't want to, lick the bottom of my shoe. And it's like, okay, ERP can be delivered in a way that's valuable to you. So make sure you're talking to your clinician if you feel like it's not as helpful as you hear it is for many people.
Totally. Duluth at 1116. I'm curious how you would advise someone who has comorbid bipolar 1 and OCD. I'm struggling with the presentation right now, but I'd like to think I'm doing okay.
Yeah, what I would say is people with OCD also have bipolar 1 or bipolar 2. I would say definitely making sure that you are working with someone specific. Typically, bipolar disorder is treated medically. You want to make sure that you're working with somebody, a psychiatrist who really understands both disorders. Sometimes people with bipolar disorder can't take certain medications for OCD. Once again, that's a great question on June 5th for Dr. Hudak, but that is something sometimes people can't take certain medications. But if somebody is taking the proper medication to help with bipolar, to really help with those manic episodes, that bipolar depression, people can live a full life and they can definitely get better from OCD. Obviously, I would say the caveat is sometimes if somebody's in a depressive episode, they might not find themselves having kind of like the energy and motivation to do ERP or any kind of OCD work. And so we want to make sure that somebody understands behavioral activation and has a really good system so that they aren't kind of just like checking out for a couple of days in the dark and home and kind of isolating. I would say it's difficult to obviously do OCD treatment during a manic episode. But the medication will help prevent from as many episodes. But yes, I have people that I work with that have both, and they're doing great with their OCD treatment.
Yeah, the big thing again is when you have a comorbid presentation, so OCD and another disorder, like it is still so treatable. We just want to make sure you're getting the evidence-based treatments for each disorder. So we're not going to treat bipolar with OCD treatment. We're not going to treat OCD with bipolar treatment, right? So it's really about as long as they're both being treated and managed, you can have incredible outcomes. Love to see the comment about the presentation that your OCD told you to prepare, but you decided not to. You'd already aced it. So love seeing that. Love seeing when people are making those values-based choices versus OCD choices.
Yes, congratulations. We don't know your real name, but 3 Cheese High on YouTube just said that they have a presentation, but they did not give into the compulsions. And that is amazing. Thumbs up all around.
Yes. A question at 1120 from Spence. Have you ever had patients with an OCD theme where you did have to rule out paranoid personality disorder, schizophrenia, or chronic methamphetamine use? So my answer to that is 100%, right? Like, again, when somebody comes to our program, we are treating complex cases. Like that's what we do. We treat very severe complex cases. And an outpatient, you can treat complex or comorbid cases. It is our job as clinicians to always be doing full intakes when somebody arrives for our care. And what that means is that we should be looking at their entire presentation, everything they're struggling with, and ruling out any comorbidities and helping give an appropriate diagnosis. So we all the time are looking at OCD and ruling out what else is going on or trying to better understand. Or some people present to us and really think that the presentation is solely OCD, and it's not. There's actually other things going on. And so we're always having to better assess and understand. And I think in our level of care, one of the things we tell all of our patients is that when you arrive, you're on a 2-week trial. And what we mean by that is that, like, for the first 2 weeks, we're really getting to know you at an intense level. And so we want you to be open that this may or may not be the right treatment for you, right? After 2 weeks, it may be, yes, this is great, you're going to have amazing outcomes, or hey, like, we've really learned that this is what we think is going on and better explains your presentation, and this is the appropriate treatment. But to the next question, I'm gonna say something opposite. The next question is, do you think there's any OCD case when there are not comorbidities? And my answer to that is yes. We also see cases that are just really severe OCD, complex severe OCD cases. So not all OCD cases have to be comorbid with another diagnosis. 100% we see many times we see a clear OCD case that can look really complex, can look like there's comorbidities, and it's only OCD. So both can happen.
Absolutely. I would say a lot of times, there are comorbid conditions and there's people that don't. I would say the more common ones, the more common two, according to the DSM, is a depressive disorder, about 68% the DSM says, or I think it's mid 70% for anxiety-based disorders. So it could be generalized anxiety, social anxiety, or social phobia disorder. But there are a lot of people that come in, like Liz said, just have OCD, and that's it. And OCD already sucks by itself, so it's like
don't need more. We don't need to add on more. We don't have to, sort of thing. But I was just looking at my books to see. But one of the questions about treatment, and then some other folks were talking about self-help options. So I want to talk about that for a second. Chris, can you share some of your favorite books, self-help resources, workbooks that are your go-tos for individuals who may not be able to afford treatment right now, but need to have some good info and knowledge and resources in their hands?
Yeah, I mean, a friend to the live streams, John Hirschfield, has some really great books. I know him as a personal person too. He's a very zen human being, very
A
calm
personal
spirit.
person, in case he was a fake person.
I meant a personal friend, but Liz and I did a presentation with him last year, and it's like it was such great chemistry, the three of us. But he's such a like zen person and a cool person, and he talks a lot about just mindfulness based interventions for OCD. But he has a lot of different variety of books, and what I like about his books, because I've gotten them, is a lot of them are workbooks, but they don't feel like, I don't know how to describe it. If you've read a John Hirschfield book, it doesn't feel like robotic and stiff. It's a very good book. I have clients that really like it. He recently put out last year a teen book for teens with OCD. Sean Shinnock did some of the art. I love Kim Quinlan's book. I was actually working with a client who's very harsh on themselves, and we were doing some of the work. There's a section that talks about kind of like the second arrow in OCD treatment. So it's her workbook on self-compassion. I always like Bruce Hyman's, like the OG, like OCD workbook. I mean, I rest in peace. He was an amazing human being, amazing clinician, wrote an incredible book. So that's just the OCD workbook. There's another book I really like, and I was just doing it with a client, was Dr. James Claiborne. He has a book, a habit change workbook, that I think is awesome. So those are some really, really good ones. I don't have it with me because I'm reading it at the office, but there's a new BFRB book and we're going to have them on the stream. It's Marla and Renee Diebler, butchering last names, but there's a lot of really good books, and the IOCDF has a good section on their website about books.
Yeah.
Do you have any faves?
Yeah, I'm going to give you some of my faves. I love John Abramowitz's self-help workbook for OCD. I love Freedom from OCD by Dr. Grayson. I love, I love John Hirschfield's self-help workbooks. Kim Quinlan does amazing CBT school that is as online program for patients with OCD. So I definitely recommend checking that out. I think it's a much more affordable option to kind of understand treatment and what it would look like. So many resources, so many options available. Next question at 11:28, who diagnoses OCD? Is it a psychologist or a psychiatrist? My son has been in therapy with someone not specifically for OCD, but it's becoming apparent that he has developed OCD in recent years, but resists treatment.
Yeah, there's actually multiple people that could diagnose OCD. What I would always strongly suggest is, whether it's a therapist or a psychologist or a psychiatrist, I would definitely recommend somebody who eats, breathes, or sleeps OCD. I would say most of the time it's going to be, some people will do psychological testing to get the diagnosis. So that would be actually where you see a psychologist. There's a lot of universities by my office that do it, like UCI, where people go in. It's typically younger kids, and they're going and getting, testing for ADHD or for autism, and some of them do OCD. But I diagnose a lot of people. They come in thinking that they might have OCD, and we do, just like Liz was saying, a very thorough clinical diagnostic assessment. So we use, the Y-box checklist, interviews, also talking about some of their symptoms. There's other assessment measures. Actually, the IOCDF has a lot of really good ones, but you want to make sure you're seeing somebody trained in OCD, because what I see happen is people might go to a general doctor and they'll say like, oh, I'm having thoughts about harming my kid. And the person is like, oh, that sounds like psychosis, or that's unsafe. We might have to take your kid away. So you really want to make sure that it's somebody that's trained in OCD and really understands the disorder.
100%. Next question. Let's go to so many. I love watching you guys talk to each other and communicate with each other. It's so great. GH at 11:29. Could you recommend how to coordinate the therapist with the medication prescriber? My son's therapist never spoke to the prescriber, an employee of the different psychiatrists who never saw my son.
Yeah, so I will say, if you have a treatment team, meaning in this case, right, like maybe your loved one, in your case, your son, is working both with a medication prescriber, whether that's a psychiatrist, nurse practitioner, et cetera, and a therapist, and maybe like the school, or maybe they're seeing a family therapist because there's some family dynamics. You want to make sure that treatment team talks. I know it helps me so much when I talk to someone's medication prescriber. What I usually do, and I don't know how Liz does it, I usually have the psychiatrists call me just because I'm way better at answering the phone. A lot of times the medication prescribers might work at a hospital or at a center like that and are harder to get a hold of. But you want to just make sure that you sign a release of information, which allows your treatment team to communicate with each other. And then they'll go ahead and set up a conversation. Sometimes a family member wants to be there, so you might have it set up as a meeting while you're in a session, et cetera, or usually just the clinicians will talk and update you about what they said. But a release of information and just talk to each of the clinicians and say, I'd like people to communicate, because I know it helps me when talking to a prescriber to find out what they're doing with medical, with psychopharmacological interventions while I'm working with a client. Some treatment centers have both on staff, and so sometimes that's a lot easier. But in this case, most of the time they're not under the same roof, and so it's better to sign a release and have them communicate for sure.
Yeah. I also think that sometimes clinicians don't feel like it's needed, so it may not be a standard part of their treatment, but you can request it. So you can always request that they are working together with the psychiatrist, ask them if they've communicated, especially if you feel like that's an important piece for treatment. It's hard for me to imagine because in res, it's like we're all talking to each other all day, but like sometimes with that fragmented care, it's tough for them to coordinate schedules. So I love that you guys give so much feedback and thoughts about how to do treatment and what different things can look like for each other, and that y'all are sharing feedback with each other.
Liz, I'm going to throw a pre-submitted question to you.
Okay.
So I'll have Amanda put it up. The pre-submission question says, can you cover avoidance and how this can be a compulsion on its own? Many professionals seem to miss this.
Yeah, so 100%, right? So what we know is that avoidance feeds the OCD cycle the same way as a compulsion. In fact, I always say I think avoidance feeds it more, just because, again, when we are thinking about treatment, one of the things we want to really be thinking about is, are we re-empowering anxiety and OCD? Are we making it bigger? Are we empowering it, or are we disempowering it? And at the end of the day, when we start avoiding because we don't want to be triggered, well, what messages are we sending? Number one, we're sending the message that OCD is dangerous, we can't tolerate it. And number two, we're sending the message also that anxiety is dangerous and I have to avoid it at all costs. And so I want you to really be engaging. And if you do rituals, we're going to remove those rituals. But if you're avoiding, now we have to kind of do two things. We have to get you back engaging, and then we have to get you to remove the rituals. But avoidance feeds the cycle the same exact way. You guys, what I want you to remember is that when we think about OCD treatment, what I want you to think about across the board is, what message are you sending to your anxiety and OCD? Are you sending this message and attitude of like, bring it on, I'm not afraid of you, across the board? Or are we sending a message of, I don't know, I can't tolerate you, this is dangerous, this is scary, I don't think I can handle this? Because again, if it's the latter, whether it's through avoidance or rituals, you are just giving OCD and anxiety fuel. But if you approach everything with this, like, bring it on, I'm not afraid of you, what else are you going to throw at me attitude, it actually starts to die down because it doesn't have any fuel. So, avoidance, it feeds OCD the same way as a ritual, if not more.
Yes.
I want us to talk for a second. I'm seeing lots of chats in the thread about breathing and the way people their OCD is kind of latching on to breathing and it's becoming ritualistic. So I want us to just kind of give an overall statement of, Chris, like, how does someone work on that if they're finding that like they're recognizing their breathing, it's becoming ritualistic, OCD and anxiety are attaching onto it?
Yeah, so we talk about OCD. The subtype specifically might be sensor motor OCD, where people get very fixated. It can be on breathing, blinking, chewing, the position of their tongue, the heartbeat that they feel. And what happens is with OCD, we know we get very fixated. When you think of the fight or flight mind, it's just keep us safe. Somebody's, chasing us in the parking lot. We want to be able to have our strong muscles to run and our senses to be able to look for safety, right? So the problem is when we're in an angst state, our fight or flight mind fixates on things and we get very aware of things. Unfortunately, OCD loves to utilize that for bad because OCD is never our friend, right? And so it might have us latch onto our breathing. And then we focus on our breathing. Now, what happens is kind of this second layer of discomfort and frustration because, like people were putting in the chat, I don't want to focus on my breathing. I can't pay attention to my class. I can't, I'm not learning from what the professor's speaking about, or it's annoying, or I can't sleep while I'm focusing on it. And so what do people do in retaliation is they try to avoid thinking about their breathing. I don't want to pay attention to my breathing. I don't want to. Go away, go away. Well, what happens? We now just become more aware of our breathing, and then it becomes a really bad cycle. And so to take OCD's power away, we got to kind of do the opposite of what seems what makes sense, right? We got to do something that feels a little counterintuitive. So someone gave a great exposure, 3 Cheese High, which is a great YouTube name, said for their ERP, what they did is they focused 30 minutes on their breathing while doing things like the dishes, getting lost in thought, go back to the breathing. This is the response prevention. So there's a really good tactic that John Grayson talks about in his book about like putting dots on like sticky notes and putting it around, or putting sticky notes around your house that say the word breathing. So, you're walking and you see breathing, and then oh no, now I'm focusing on my breathing, and be like, yes, I am focusing on my breathing. How can I get through the rest of the day like my dishes and continue to focus on breathing? You are taking OCD's power away when you stop fighting and getting frustrated. So that's why you want to work with a trained clinician, because you want to work on it in a way that you're learning like, hey, if I pay attention to my breathing, I don't have to panic and get frustrated and add more anxiety to it, which is just in turn going to make me more focused on it because now I'm in my fight or flight brain. But thank you, 3 Cheese High, for an example of an exposure. I had it a lot with my swallowing. So what I used to do is just sit there and like drink liquids for ERP and just focus on my swallowing. And it became extremely boring. And just like they were saying in the chat, it was so hard to do the ERP after a while because I'm like, this is so boring just focusing on my swallowing. But I got over it. So if I started noticing my swallowing organically, I was like, yep, I noticed my swallowing now. That's my new thing. And it became pretty boring.
So, and again, I just want to say for a second, I saw somebody say something like, okay, so I guess what I do is I just breathe normally. I guess my exposure is to breathe normally and quit thinking about it. Wow, that's going to be hard. And so my response to that is that like, yes and no. So again, that is the goal of treatment. The goal of treatment is that you're going to be able to breathe normally and not think about it. But if you could just do that, you wouldn't have OCD. Right. So if like so many times I think people think like, well, why do you need to make this person do ERP? You should just they should just go do those things without having to get stuck or worry. And it's like, well, yeah. And that'd be great if you can let us do that. Like, don't you think all of us with OCD have tried to just not think about it or, just act normally and not have these triggers, but we have OCD. That's the definition of OCD, is that we can't do that on our own. And so I say that just because I want to make sure we understand that the point of ERP treatment is that it is going to get us there. It is going to get you to where you can do these normal activities. I can be with my kids, change their diapers, bathe them, and not have intrusive thoughts. I can drive a car and not have intrusive thoughts. That's awesome. But the only way I got there was by doing ERP along the way. Now, that doesn't mean the way I did ERP had to be this depressing way that I had to think these horrible thoughts about myself and think that my worst case fears were truth. No, I didn't have to do that. That isn't what ERP doesn't have to be. That it doesn't have to be where we imagine that we're a pedophile or we accept that we might kill someone when we're driving. I'm not going to do either of those. I wouldn't be willing to do treatment. But it does mean that I have to be willing to tolerate the uncertainty, the distress, the thoughts that OCD throws at me with choosing not to solve them, just like everybody else does. The difference is that other people who don't have OCD don't even notice they're doing that, right? My husband has weird thoughts about our kids and he lets them come and go and doesn't respond to them and doesn't do anything about them. And so they don't bother him. Yes, I want to get there, but if I'm triggered by my weird thoughts about my kids, the only way I'm eventually going to get to a place of them not bothering me is to be able to allow that distress and those weird thoughts to be there and choose not to answer them and then move through it. So right now, when you're really triggered about the breathing, you are going to have to slow down and notice, wow, I'm worried about my breathing. I want to figure this out. I'm going to choose not to figure it out and move forward. So you have to kind of allow some space for that distress, for that discomfort, and choose to leave things unanswered. answered so that eventually you can breathe normally and not be triggered by it. And so I just want to say that because I think sometimes the way we hear it is like the way we hear ERP treatment is, you know, for example, I hear people all the time talking about like, man, I can have, dropping my pen, I'm stuck in my hair, fun. I hear people talking about like, I can have this intrusive thought and still go do this values-based activity. And it's like, yes, you can, but that isn't what treatment should be forever. Treatment shouldn't be that we think we're always going to have these horrible, scary, terrifying thoughts and we just have to like push through them, right? That's actually not effective treatment. Like effective treatment is we have thoughts and we actually allow space for them and choose to leave them unanswered so that we can actually dissolve the fear and anxiety around those thoughts. And in the future, we won't have those anxiety provoking thoughts. We'll have the thoughts, but they won't be anxiety provoking and they won't come as much.
Yeah, no, well said.
Denzo at 1136. Love that name. Is there a tip for living in the moment with existential OCD? It feels like I forgot to live.
Yeah, I'm glad you asked this question, Denzo. I would say one of the things I wanted to talk about with existential OCD, because I think a lot of times compulsions don't always feel as overt. I'm working with a few different clients that are experiencing existential OCD, and a compulsion that they didn't even realize was a compulsion is they're just sort of like not doing life. They just don't really see the point. They're like, what's the point? I don't even know if I'm really here. I don't know if this is even real. I don't know my purpose. Everything feels so mundane. So a lot of them as a compulsion is they're not living in the moment and they're not living at all, right? Like I have one of my clients who's like, I don't want to go to college. What's the point, right? So there's like a lack of interest in engaging with life because for some people, it depends on how existential OCD specifically shows up. But some people, it's like, am I even really here? Who am I? What's my presence on this earth? What's purpose? Everything feels so mundane. And so a lot of times, I think what people are waiting for, whether it's existential OCD or any subtype, is they're waiting for this like feeling. We were fortunate enough to have Nathaniel Van Kirk, an amazing clinician, come to my recent family and loved ones OCD support group, and he talked about the myths of motivation for treatment. Like we need this like feeling to come in to feel like, you know, like we're going to go do things. And with existential OCD, you may not have that feeling. I mean, I have clients that are literally like, this feels like the Matrix, or this feels like an alternative reality. I don't even feel like I'm here. Why would I go to school, etc. Sometimes we're going to have to do things, even if we don't feel like doing it. And so what I hear from a lot of clients, I'd be curious in the chat if this is how you resonate, but they're like, I can't live in the moment because my brain is so trying to figure out philosophers' questions, or what about the afterlife, or all these like big, profound questions that nobody's been able to answer with certainty thus far. And so it's getting back to the basics, like what is important for you? Is it relationships, etc.? And it's going to feel like an exposure, like Liz was saying earlier, to not answer these questions, to not trying to figure out big questions. Am I here? What's the purpose of life? What happens after we die? Who came before us? All these questions that I get asked all the time in class, in session. So living in the moment may feel dull. It may feel small. It may feel insignificant. But if you start to engage in those living things while not answering the questions, it's going to feel like an exposure. And that's, you know, that's going to happen despite feeling like you want to do those things. I don't know if you want to add anything or if you felt. Oh, you're muted.
I said, look at my hair. It's like that pen got stuck. I don't know how I can add anything seeing myself in there. Sorry. Yeah. So no, I love you guys. I totally agree and love all the questions and stuff that keeps going. Let's see what to get to next. Avoidance.
While you're looking for that, I have a question. Oh, sorry.
Love the question from Michael at 1143. So I'm going to start with that. Then you throw yours to me, Chris. Sorry, my lagging internet is getting us. Looking to move to Kansas City next year after living in the same city my whole life with my family. I'm afraid OCD and anxiety are going to challenge it. What do you recommend?
Oh, that's our buddy Michael. I love Michael. Michael is severely the most positive and like loving person on the planet. So I just want to shout out Michael. I saw him at a conference in Colorado, and he is without a doubt like an amazing human being. So Michael, I just want to say, please don't ever lose that. Yeah, moving into a big city from the city you're used to, and moving on your own is going to be absolutely scary. I would say, to normalize it for you, I saw a study once, and after public speaking, like one of the top stressful things for people, everyday kind of things, is moving. So moving is stressful. You're moving to a bigger city. You're moving out of your family's home. Here's the thing. When we can flip our mindset to start to think that anxiety, distress, uncertainty, all these things, doubt, feelings of uneasiness, we don't have to look at those and classify those things as bad. Those are things that are essential for growth. So for you, Michael, in order to kind of like move to the next phase of your life and moving into a big city and being on your own, there's going to be growing pains. There's so many things that could go wrong. There's things that can go right. There's things that are going to be in between. And what OCD wants us to do is to say, I need to come up with every problem that can happen and solve them before I move. And that is not helpful. In fact, that's just going to have you fixate on all the bad things, and you're going to be more inclined to do compulsions. There may be a whole lot of things that are unknown and scary and spooky, but that's what I love about the philosophy of ERP. It's this idea of like, I'm going to go through it. I love when Kim Quinlan says, like, it's a perfect day to do hard things. So it is going to be some growing pains, Michael, because let me tell you, when I first moved out of the home, it was very, very stressful, but it was incredible. It was amazing. It was independent. So when we look at most things in life, whether it's like becoming a therapist, you have to go through so much gruesome school for it, right? Or to get in shape, you have to work out and it's painful. Or to have kids, right? It's painful to have the child, as Liz knows, physically, but then there's a lot of stress when they're younger. So my point is, in order to achieve great things in our lives, there's going to be ups and downs and struggles and hard moments and uncertain moments and moments that you doubt yourself, right? But if you really push through and pick it up, you get all the amazing rewards that come with it.
100%. Couldn't have said it better. Go ahead.
I'll toss you a pre-submitted question. They said, my clinician uses CBT and EMDR with me, but I've been in therapy for 10 years and still struggled very badly. How can someone who's been doing therapies that are not frontline and evidence-based for OCD specifically, like how can they maybe approach their therapist? Because the reason I liked this question is I think some people, if they've been with a therapist for 10 years, that person is like almost part of their life. Like, how do they approach somebody that they've trusted for so long to say, hey, I'm really starting to think that this isn't the right treatment for me, and I think we need to try something else, or I think I need to work with somebody else?
Yeah, great question. So it is really important to know that OCD treatment should be successful pretty quickly. In as little as 12 to 16 sessions, you should start to see differences, outcomes. You should start to feel like you're making progress. You shouldn't feel like you're plateauing and that things aren't getting better, or certainly not that you're getting worse. 10 years into treatment, you should be a totally different person. And with effective OCD treatment, you should be experiencing freedom from your OCD, and way earlier and sooner than 10 years in. What it gets a little bit confusing is that sometimes people interchangeably say CBT is an evidence-based intervention for OCD, because what happens is ERP falls under the CBT umbrella. So it feels like, well, CBT is evidence-based, but actually CBT treatment alone, so CBT modalities, are not evidence-based for OCD. They actually end up getting people a little bit more stuck because they're more kind of a lot of cognitive and different approaches. It needs to be ERP specifically, not CBT. It has to specifically be ERP treatment. EMDR is not an evidence-based treatment for OCD. So if you're struggling badly with OCD and your clinician is using CBT and EMDR, that actually makes sense that you're still struggling. And I want you to experience and have hope that, wow, I just maybe haven't had the right specific treatment intervention. And I want you to be willing to talk openly to your clinician about that. Like, I've loved our time together, but like, I really feel like it's time that I go get specialized OCD treatment. I would recommend that you find an OCD specialist, because if this provider was one, they would already be using those tools with you after 10 years. If they're using these intervention techniques and you're not seeing the progress, I would go ahead and move forward with a different specialist who really specializes in ERP specifically.
Yeah, no, I say that as well. I mean, 10 years of therapy, you should, like you said, be a different person. I think it's really great. I want to ask you this question because I think it's something that people get stuck on. It was a pre-submitted question. They're asking, are they doing the treatment right? So they have sexual orientation OCD, and when they go in public, they get kissing thoughts about kissing somebody of the same sex. Now I don't pay attention to thoughts, and I notice the anxiety and wait to go. So if somebody has sexual orientation OCD, let's say they're in public, they're noticing, they're getting thoughts about kissing someone of the same sex. How would you advise them to kind of sort of handle both the thoughts, maybe the feelings of anxiety, and the behaviors?
Yeah, it's a great question. So again, I think exactly what you're doing, which is that you don't pay attention to them, and you notice the anxiety. But what I want to say is make sure you're not trying to suppress them. So sometimes when folks say, I have these thoughts and I don't pay attention to them, it's like I try to say, like, I'm not going to think about those. I'm going to move forward. That I'm not going to think about it is still sending that message I talked about earlier, you guys, of like, this is dangerous. I can't think about it. I can't tolerate it. Instead, I want you to be like, oh, interesting thought. Like, who knows what that means or why that's there, and you still move on and keep doing what you're doing, right? Keep engaging in that same activity. So again, don't treat the thought as if like I have to ignore you or I don't want to think about you. Actually, like allow space for the thought, but choose to leave it unanswered and move forward.
Yeah, exactly. And I would say the strongest thing when people ask, like, what are purposeful exposures that I can do? I always tell people, if you know going in public is going to bring on the thoughts, make sure you're going out in public. Because if you're hanging out at home and the thoughts don't come, the problem that's going to happen is at some point in your life, you're going to have to leave your home. And so if you have to leave your home and then the thoughts come rushing in, now you're playing defense. So people will ask, like, why do I have to do exposure? Here's a good conversation I want us to have, maybe to end the live, Liz, because I'd love to get your opinion. A lot of people will tell me, why do I have to do exposures, or why do I have to deliberately bring stuff on? My life is an exposure. And what I tell people is there's a big difference between every time you have to go to out of the house, you're having images of kissing somebody of the same sex and you're playing defense and you're like, okay, I can't give into the thought and I have to have the anxiety. And it's just this like constant battle. Whereas like, you know what? 5 times today, I'm purposely going to leave the house. You know what? I'm going to go these places because they trigger me. So maybe the gym, that seems to affect a lot of people with sexual orientation OCD. I'm going to go to the gym. I'm going to work out, and I know thoughts are going to come, and I'm going to be ready for it. So when people set the time aside, it is a way different experience. And in fact, I believe when people are purposely seeking things out, that's where the real work happens. And the good thing is, if you're doing things that are values-based, going out shopping, going out to the grocery store, going to the gym, going out in public, those are things you probably want to be doing anyways, but you're going out there almost like on a hunt to be like, how can I get better? Versus waiting till you have to leave the house with your parents and you're like, okay, I'm gonna be in protective mode. I always feel like we're on the wrong foot.
I wanna hop into that for a quick second, if that's okay, and then I know we have to wrap up. If you're saying things like, well, why do I need to purposely approach that? Just living my life as an exposure. You guys, that tells me that you are using treatment to function versus using treatment for freedom. It is much harder to slow down and purposely approach these things and allow space for them. But that will allow you to totally move through them and for them to have zero grip on your life anymore and for you to have freedom. But instead, if you're using ERP to function, so like I'm living my life and I'm doing these things and I'm doing ERP and I'm like having to face them every single day, that's like not actually what ERP should be. ERP should not be something that we are doing to function. When we're using it in that way, we're actually just using ERP to like extinguish certain fears. But that's when we hear people say ERP is exhausting. I have to do it forever. It's like, it's just this brutal thing. That isn't what we want. We want you to slow down and actively address those core fears and what's at the root so that you get freedom. Because guess what? I do want you to no longer have to do ERP every day, but I want it to be because you're just truly living your life. Not, I do exposures every day through living my life, right? There's a huge difference in saying like, oh, I have to go live my life, which means I have to go do exposures and I already have to do ERP every day. That tells me we're not like actually doing ERP all the way. We're doing ERP to function. So Chris, I want to bookmark that as our next live stream. Are you using ERP to function or are you using ERP to obtain freedom? And I want us to slow down and walk individuals through the differences and what that can really be like. Because I can tell you, as someone who's been advocating for 20 years, my own personal personal language, understanding, and treatment has drastically shifted. When I first started treatment, I thought, and I was taught, that ERP was the only way I could function, and that the goal of ERP was to get me to function with OCD. But now I know it's so different, and I really want to make sure everybody else feels and knows the same thing.
Well said, Amanda. Bookmark that. I think it's a great topic for us to approach for sure. I'll give my final thoughts, and then I'll let you give your final thoughts, Liz. But definitely, I think that's a really good topic because I think it's a huge difference. And sometimes there's mixed messaging out there on social media and other places. And so I think a lot of times when I hear clients that are like, "Oh, I do ERP because my life is a trigger," I'm like, that's sort of reaction. Let's get you back to thriving, right? So my last two final thoughts is, one, I just realized what a mess behind me every time she puts up a question, a mess behind me over there. I went to a convention this weekend and I literally won 3 times. I had raffle tickets and I won. So I laid out all my winnings on my table and forgot to clean it up before.
What are they? What did you win?
So it was like a huge, like,
do a show and tell. We want to see.
It's like a movie and a tech convention. So I won movies, comic books. I won a Stanley Cup. I won like those pop bobbleheads. I won a bunch of bags. I won all this stuff. It was like not even stuff I necessarily wanted, but I just wanted to win, and I won. So I'm so excited.
I love you for that.
But I was putting it out to like see which ones my friends want and take a picture, and then I forgot to put it away. So I'm like, people are gonna be watching.
I'm such the opposite of a minimalist. So like everything I win, it's like donated to someone because I don't like things. And then we've got Chris over here spreading all of his goods out.
I know. And Liz, I missed you this weekend. I went to the Greek festival with my friends.
Oh, of course you did. Of course you
were
did.
Invited.
And guess what? I was invited. Yeah, thank you. And next week, you guys, we are going to be asking Chris what Greek food he ate for his birthday.
Yes, I'm getting Greek food for my birthday on Sunday. Oh, and I got some honey for Ikaria, which is one of the blue zones where people live to past 100 years old in Greece. So I'm going to be going there next year. So anyways, enough about me. My real final thought, though, is I just want to say, like Liz already kind of mentioned it, in the chat, y'all were on fire. You supported each other. You offered resources. You gave each other props for the successes that you're having. Liz and I do this because we love this community. We love y'all. We love y'all being here every week. So make sure to join us every Wednesday at 9 a.m. Pacific, 12 noon Eastern. We really appreciate you hanging out with us for a lunch and learn or for an Ask the Experts. Boom. How about your final thoughts?
Couldn't agree more. Yeah, love the support. Love being a part of it. This is the best community. I will say that forever. Couldn't live without you guys. Hope y'all are planning to attend the conference. Please make sure you go to IOCDF.org to learn more about the upcoming conference. As always, I've seen a couple people in the chat struggling. If you're feeling unsafe or suicidal, please call 988 or go to your local emergency line because we are not a suicide crisis. If you're feeling hopeless, depressed, but not unsafe, please make sure you're seeing a clinician and talking to them about that and getting the support that you need. Thanks, you guys. As always, help and hope are always available. I can't wait for our next live stream where we're going to talk about freedom over functioning and how we get there. Bye, you guys.
Take care. Thank you for the birthday wishes. Yes, Greek food's amazing. And don't forget, May 31st, early bird signups for the conference ends. So if you want to get that early bird discount, it's May 31st.